Discussion on ECG features suggesting epicardial origin of ventricular tachycardia. This is important in taking epicardial access during ablation. ECG criteria suggesting epicardial origin of ventricular tachycardia can be divided into interval criteria and morphology criteria. All the interval criteria are based on the fact that there will be initial QRS widening when the ventricular tachycardia originates from an epicardial focus. This is because the epicardial focus is away from the Purkinje network while endocardial foci are nearer the Purkinje network. Important interval criteria indicating an epicardial origin of the ventricular tachycardia are 1. Intrinsic heart deflection time more than or equal to 85 milliseconds. 2. Shortest RS complex more than or equal to 121 milliseconds. 3. Maximum deflection index more than or equal to 0.55. Intrinsic heart deflection time is measured from the earliest ventricular activation to the peak of the R wave in V2. RS complex duration is measured from the onset of ventricular activation to the nadir of the S wave in any of the precordial leads. Maximum deflection index is the duration from the earliest activation to the peak of the largest amplitude deflection divided by the total QRS duration measured in precordial leads. Morphology criteria for epicardial origin of VT on ECG are 1. Q waves in lead 1 and no Q waves in inferior leads. 2. Pseudo delta wave more than or equal to 34 milliseconds. Q waves in lead 1 and no Q waves in inferior leads. Q wave in lead 1 is one of the most sensitive criteria indicating an epicardial origin of ventricular tachycardia. It would indicate an initial rightward activation from the left ventricular basal epicardial region. The criterion has a sensitivity and specificity of 88%. Absence of Q waves in inferior leads had a sensitivity of 94% to suggest epicardial origin of ventricular tachycardia. Pseudo delta wave more than or equal to 34 milliseconds. Pseudo delta wave duration is taken from the earliest ventricular activation to the onset of earliest fast deflection measured in any precordial lead. Pseudo delta wave represents the transmural activation time from the epicardial region to the endocardial region where the conduction system is located. Heyde syndrome is acquired von Willebrand syndrome in severe aortic stenosis. Severe gastrointestinal bleeding can occur in those with severe aortic stenosis. The initial description of Heyde syndrome was in 1958. An important mechanism for the bleeding is deficiency of large von Willebrand fracture multimers. This is due to the structural damage to the large protein when blood passes through the severely stenotic aortic valve as a high velocity jet. Loss of large multimers can be measured as the large von Willebrand factor multimer index, and it is significant if less than 80%. Anemia due to Heyde syndrome improves after aortic valve replacement. The gastrointestinal bleeding due to angiodysplasia, though mostly described in severe aortic stenosis, has also been reported in hypertrophic obstructive cardiomyopathy. Increased production of vascular endothelial growth factor due to reduced pulsatile flow and impaired intestinal flow is thought to be the reason for gastrointestinal angiodysplasias in aortic stenosis. For this reason, thalidomide, which inhibits the expression of VEGF, has been used for treatment of Heyde syndrome. Octreotide, which can reduce intestinal blood loss by vasoconstriction, in combination with thalidomide, may be more beneficial for the initial treatment of Heyde syndrome. Just as Heyde syndrome resolves after aortic valve replacement, it can resolve after transcatheter aortic valve implantation or TAVI. High altitude pulmonary edema is characterized by inhomogeneous pulmonary vasoconstriction in response to reduced oxygen concentration in the inhaled air at high altitude. It may be noted that oxygen is one of the most potent pulmonary vasodilators, which is used therapeutically in the management of chronic pulmonary hypertension by way of nocturnal oxygen therapy. In high altitude pulmonary edema, the inhomogeneous pulmonary vasoconstriction leads to elevated pulmonary capillary pressure and leakage of fluid into the alveoli. Oxygen therapy and descent to lower altitudes are the logical answers for the treatment of high altitude pulmonary edema. Drugs like sildenafil, tadalafil and nifedipine have been used as pulmonary vasodilators in the management of high altitude pulmonary edema. Dexamethasone is also considered useful in high altitude pulmonary edema. A slow ascent of not more than 300 meters per day above altitudes of 2500 meters to allow acclimatization can be useful. Shorter stays of less than 5 days are also recommended in those prone for the disorder. Defective alveolar fluid clearance may be an important component in the pathogenesis of high altitude pulmonary edema. Ultrasound lung comets have been detected as evidence of subclinical high altitude pulmonary edema in recreational climbers rather frequently. Portable hyperbaric chamber has also been used in the immediate management of high altitude pulmonary edema. Indicators of a large left-to-right shunt are cardiac enlargement, presence of flow murmurs, third heart sound, and a wide pulse pressure in case of patent ductus arteriosus. Left-to-right intracardiac or extracardiac shunts typically increase the pulmonary blood flow. In a large left-to-right shunt, the QP by QS, that is the ratio of pulmonary to systemic blood flow, is more than 2:1. Features of large shunt depend on the level of the shunt and also whether it is pre or post tricuspid. Pre-tricuspid shunts occur at the level of the great veins and at the atrial level. Post-tricuspid shunts are either at the ventricular level or at the great artery level. Pre-tricuspid left-to-right shunts are either due to an anomalous drainage of pulmonary veins to the right side of the heart or an atrial septal defect. The flow into the right atrium, right ventricle and pulmonary artery are increased, leading to dilatation of all these chambers. Pre-tricuspid shunts seldom produce heart failure as the LV is not affected. Tricuspid diastolic flow murmur and an RV third heart sound are audible in case of large shunts. Pulmonary ejection systolic murmur due to enhanced flow is universal and in fact more easily audible than the tricuspid flow murmur. RA enlargement may be recognizable clinically by the rightward enlargement of the right cardiac border. Here is an X-ray chest PA view in AST which had large left-to-right shunt showing enlargement of right atrium, main and right pulmonary arteries. Left pulmonary artery shadow is behind the cardiac salute. Branch pulmonary vessels are enlarged and end-on views are seen. Right ventricular type of upturned apex is visible. Peripheral pruning of pulmonary vessels indicate severe pulmonary hypertension. The classical post-tricuspid shunts are ventricular septal defects and patent ductus arteriosus. The other post-tricuspid shunts, truncus arteriosus and aortic pulmonary window, are less likely to manifest a large left-to-right shunt due to the early development of severe pulmonary hypertension, which reduces the magnitude of left-to-right shunt in spite of a large defect. Post-tricuspid shunts cause left ventricular overload and failure in infancy. Flow murmur in the mitral area and left ventricular third heart sound are heard in post-tricuspid left-right shunts. A finding unique to a large PDA is a wide pulse pressure due to aortic runoff. X-ray chest PA view in a VST with left-right shunt and hyperdynamic pulmonary hypertension. There is cardiomegaly, prominent main pulmonary artery segment and right pulmonary artery. Enlarged left pulmonary artery shadow is seen below the left cardiac border within the cardiac salute. The enhanced vascular markings are visible on the right side, whereas it is obscured by the cardiac shadow on the left side. Katz-Wachtel phenomenon bar sign is tall diphasic RS complexes at least 50 mm in height in leads V2, V3 or V4, that is the mid-precordial leads. The sign has been described in VST with large left-right shunt and biventricular hypertrophy in children. Jaccoud's arthropathy is a deforming arthropathy of small joints of the hand and feet secondary to rheumatic fever. Now the term Jaccoud's arthropathy is being used for similar pattern with SLE and other immune-mediated disorders. Usually, rheumatic fever involves the major joints and is a non-deforming arthritis. Jaccoud's arthropathy is due to periarticular fibrosis and it is called as a correctable deformity, unlike the deformity in rheumatoid arthritis, which is fixed. Earlier on, when rheumatic fever was quite frequent, Jaccoud's arthropathy used to be confused with rheumatoid arthritis because of the deforming nature. Separation was occasionally more difficult when there was a family history of rheumatoid arthritis and a positive rheumatoid factor. In a prospective study involving 400 patients with rheumatic valvular heart disease, 17 patients had diagnostic features of Jaccoud's arthropathy. All these patients had a past history of acute arthritis. None of them had pain, signs of inflammation, or functional deficit at the time of diagnosis of Jaccoud's arthropathy. Other causes of joint deformity were ruled out by radiological and serological studies. Conventionally, Jaccoud's arthropathy has been considered as a delayed manifestation of rheumatic fever. Nowadays, similar findings are more commonly reported in systemic lupus erythematosus. Jaccoud's arthropathy is characterized by swan neck deformity, ulnar deviation, and set thumb as in rheumatoid arthritis. But the deformity can be corrected passively. There is no bone erosion noticeable on plain radiographs. Bone erosions and other structural changes may be documented by magnetic resonance imaging. Typical features of Jaccoud's arthropathy has been reported in patients with sarcoidosis. Jaccoud's arthropathy has also been reported after treatment with nivolumab. Nivolumab is a novel immune checkpoint blocker given for metastatic clear cell renal cell carcinoma. There were no diagnostic features of SLE in this patient. Discussion on lithium and sinus node dysfunction. Lithium is used in the treatment of bipolar disorder. It has a narrow therapeutic index, that is range between therapeutic dose and toxic dose. Lithium can cause bradycardia directly by its effect on sinus node or indirectly through induction of hypothyroidism. Sometimes the bradycardia may be severe enough to require temporary pacing. Usually the bradycardia improves once the lithium levels come down. Thyroid status also improves after withdrawal of lithium. It must be remembered that diuretics can aggravate lithium toxicity as lithium is selectively reabsorbed by the renal tubules. This can also occur in association with sodium deficiency or dehydration secondary to vomiting or diarrhea. Renal disease can also precipitate lithium toxicity. There is also a case report of irreversible sinus node dysfunction occurring after restarting lithium. The person had initially developed sinus node dysfunction with long-term lithium therapy, which improved on discontinuing lithium. But after resuming low dose of lithium, irreversible sinus node dysfunction occurred, not improving by stopping lithium again, and a permanent pacemaker had to be implanted. This report gives a suggestion that it may be better not to re-challenge with lithium once the sinus node dysfunction improved after withdrawal of the drug. It may be prudent to consider an alternate medication. Lithium is a potent blocker of cardiac sodium channel, which could have a role in lithium-induced bradycardia. Sinus arrest, while it was being used in a therapeutic dose requiring permanent pacemaker, has been reported. Lithium therapy was continued in this case after insertion of rate-modulated ventricular pacemaker. Lithium-induced sinus node dysfunction can also occur within therapeutic levels of lithium as mentioned above. Therapeutic levels of lithium are in the range of 0.6 to 1.2 milliequivalents per liter. In another case, sinus node arrest and intermittent junctional escape occurred at serum lithium level of 0.7 millimoles per liter. The patient was supported with temporary pacing and the condition improved after withdrawal of lithium. Serum electrolytes and thyroid function were normal in this case. In another similar report, symptomatic sinus bradycardia occurred at serum lithium level of 0.55 millimoles per liter. The patient improved after lithium withdrawal and did not need pacemaker support. This lecture discusses long and short RP tachycardias. It is a classification of supraventricular tachycardias based on the RP interval. Long and short RP tachycardias are two groups of supraventricular tachycardias depending on the interval between the R wave and the P wave of the next cycle. In the ECG shown here, RP is shorter and PR interval is longer than the RP interval. This is a short RP tachycardia. Typical slow-fast AV nodal reentrant tachycardia is the most common type of short RP supraventricular tachycardia. It is called slow-fast tachycardia in which impulse travels downwards through slow pathway and back through the fast pathway. P waves are not seen in 80% typical AVNRT because it is within the QRS. In 20% it is visible just after the QRS. Accessory pathway mediated atrioventricular reentrant tachycardia is the other form of short RP tachycardia in which the P wave falls at the end of the QRS. Long RP tachycardias include a typical fast slow AVNRT in which the impulse travels down the fast pathway and back through the slow pathway. Since the return circuit is slow pathway, RP interval is longer than the PR interval. Other forms of long RP tachycardia are atrial tachycardia and PJRT or permanent junctional reentrant tachycardia. Sinus tachycardia is also a differential diagnosis for long RP tachycardia which must be differentiated mainly by the P wave morphology and axis, which will suggest the activation sequence from the sinus node downwards into the both atria. Mahaim fibers are a type of accessory pathways connecting the atria to the vesicular conduction system in the ventricles. Nodovesicular pathways have also been described. They have decremental conduction properties like the AV node. No delta wave is usually seen in sinus rhythm with Mahaim fibers, though it is a form of pre-excitation. Mahaim fibers do not conduct retrogradely. So, Mahaim fiber tachycardia is always with a wide QRS complex antidromic LBBB pattern. Mahaim fibers are usually located around the tricuspid annulus. The fibers are peculiar in that loss of conduction can occur even with trauma due to the electrophysiological catheter used for EP study. Specific Mahaim potentials known as M potential generated by the accessory pathway can be recorded in certain cases and is useful in guiding successful radiofrequency ablation. Mahaim junctional acceleration occurs during RF ablation as in case of AV nodal reentrant tachycardia. Mahaim acceleration during RF ablation has been considered as a predictor of successful ablation. Slow spontaneous automaticity of distal Mahaim fiber during RF ablation has also been reported. Rare cases of left-sided atriovesicular pathways have appeared in literature. In one case, the Mahaim pathway with decremental antegrade conduction was located in the mitral annulus aorta junction between the left and right fibrous trigones. Thus, it was situated in the supraoccipital aspect of the mitral annulus rather than along the tricuspid annulus. Typical Mahaim fiber tachycardia has a left bundle branch block morphology with left axis deviation and a late precordial RS transition. Baseline ECG may not show any significant change in case of Mahaim fiber, though an LBBB pattern with normal PR interval may be seen sometimes. Reverse Pulsus paradoxus is an expiratory fall in pulse volume, the opposite of Pulsus paradoxus. The classical causes of reverse Pulsus paradoxus described are isorhythmic AV dissociation, hypertrophic obstructive cardiomyopathy, and intermittent positive pressure ventilation. In isorhythmic AV dissociation, inspiratory increase in sinus rate results in sinus rhythm dominating over AV dissociation. While in sinus rhythm, there is AV synchrony and hence higher pulse volume compared to AV dysynchrony in expiration. The ECG shows the typical fluctuation in PQRS relationship with nearly identical atrial and ventricular rates. In isorhythmic AV dissociation, inspiratory increase in sinus rate results in sinus rhythm dominating over AV dissociation. While in sinus rhythm there is AV synchrony and hence higher pulse volume compared to AV dysynchrony in expiration. The ECG shows the typical fluctuation in PQRS relationship with nearly identical atrial and ventricular rates. During IPPV, the swings in intrathoracic pressure is opposite to that of normal breathing. Hence, the inspiratory blood pressure is higher than expiratory blood pressure. During the inspiratory phase, increased intrathoracic pressure of positive pressure ventilation is transmitted to the aorta. In addition, there is an increase in the left ventricular stroke volume. The occurrence of reverse Pulsus paradoxus during IPPV has also been called as respirator paradox. It has been mentioned that respirator paradox after cardiac surgery may delay the early diagnosis of cardiac tamponade. Reverse Pulsus paradoxus in a patient on IPPV is thought to be a sensitive indicator of hypovolemia. LV and systolic volume as measured by radionuclide imaging is reduced during inspiratory phase of IPPV without significant change in end diastolic volume. This would suggest a reduced LV afterload in inspiratory phase as a mechanism for reverse Pulsus paradoxus in IPPV. Medina classification is a popular classification of coronary bifurcation lesions. Medina classification of coronary bifurcation lesions involves assigning a binary value 1 or 0 to each of the three components of a bifurcation, that is proximal region of the main branch, distal region of the main branch and the side branch. If there is more than 50% stenosis, a value of 1 is assigned. A value of 0 is assigned if the stenosis is less than 50%. If only proximal segment of the main branch has a significant lesion, it becomes Medina 100. If distal branch of main branch alone is involved, it becomes 010. Sole involvement of side branch is designated 001 and involvement of all the three is designated 111 and so on. True bifurcation lesions are those belonging to the Medina classes 111, 101 and 011, where both the main branch and side branch are significantly narrowed. While treating true bifurcation lesions, consideration should be given to the extent of the disease in the side branch, whether the lesion is limited to the ostium or involving the vessel beyond the ostium, size of the side branch, angle of takeoff, and the territory of distribution of the side branch. Interestingly, this often well-quoted classification in interventional cardiology was initially published as a letter to the editor by Medina A and colleagues. Discussion on chest X-ray in left to right shunts. Chest X-ray is a simple, cheap and easily available investigation for the evaluation of left-right shunts, but it is often avoided in pediatric age group due to concerns of radiation. Cardiac size and lung vascularity can be readily assessed and followed up serially. Lung vascularity pattern is different in pre-tricuspid and post-tricuspid shunts. Pattern changes with the development of pulmonary hypertension as the shunt decreases. Cardiac size also decreases when the shunt decreases. Cardiac chamber enlargements are also different according to the level of the shunt. This chest X-ray in atrial septal defect shows grossly dilated main pulmonary artery. The right pulmonary artery is also quite enlarged. Right atrial enlargement is seen as a shift of the cardiac contour to the right of the spine. Pulmonary vascularity is increased and prominent end-on vessels are seen. Apex is upwards, suggesting a right ventricular configuration. All features suggest a large secondum AST with a large left to right shunt producing severe pulmonary hypertension. Cardiomegaly on chest X-ray is suggestive of AST in Eisenmenger syndrome, while it is unlikely in VST and PDA Eisenmenger. Cardiomegaly is mainly due to grossly dilated right atrium in atrial septal defect. The right atrium is not enlarged in the other two varieties of Eisenmenger syndrome. In ventricular septal defect with large left-right shunt, the cardiac size comes down as pulmonary hypertension develops and the shunt decreases. Cardiomegaly in VST and PDA with large left-to-right shunt are due to left ventricular enlargement, but this comes down with the development of pulmonary hypertension. That is why cardiomegaly is not a feature of Eisenmenger syndrome due to VST and PDA. X-ray chest PA view in atrial septal defect with severe pulmonary hypertension. Prominent main pulmonary artery, right pulmonary artery and left pulmonary artery behind the main pulmonary artery and end-on views of dilated branch pulmonary arteries are seen. Echocardiography documented large secondum AST with severe pulmonary hypertension and bidirectional shunt across the AST. There is mild right atrial enlargement and the configuration of apex is right ventricular. Absence of significant cardiomegaly would suggest that the pulmonary hypertension developed early before very large shunt was established. In AST, shunt is fully established only when the right ventricular muscle mass regresses. Some cases with higher pulmonary vasoreactivity develop pulmonary hypertension early. Prominent central pulmonary artery in acute massive pulmonary embolism is called Fleischner's sign. Some authors extend the term to prominent central pulmonary artery due to other causes of pulmonary hypertension as in ASD. Chest X-ray is normal in a small VST. Large VST will have left ventricular type of cardiomegaly and pulmonary congestion in infancy before the development of pulmonary hypertension. Pulmonary hypertension manifests on CXR as prominent main pulmonary artery segment and prominent right descending pulmonary artery. Close scrutiny may show the dilated left pulmonary artery within the cardiac silhouette. When severe pulmonary hypertension occurs, cardiac size decreases due to decrease in the pulmonary blood flow, but pulmonary arteries become more prominent. Initially, pulmonary vascular markings are prominent and seen up to the periphery of the lung fields with large left-right shunt. When vasoreactive pulmonary hypertension sets in, there is peripheral pruning with decrease in vascular markings in the periphery of the lung fields. X-ray chest of a child with VST left-to-right shunt and hyperdynamic pulmonary hypertension. There is cardiomegaly, prominent main pulmonary artery segment and right pulmonary artery. Enlarged left pulmonary artery shadow is seen below the left cardiac border within the cardiac silhouette. The enhanced vascular markings are visible on the right side, whereas it is obscured by the cardiac shadow on the left side. This child ideally needs cardiac catheterization for evaluation of shunt and pulmonary vascular resistance and its reversibility to decide on surgical option. X-ray chest in PDA with large left to right shunt will show cardiomegaly and increased pulmonary vascularity as in other large left-right shunts. In PDA, an additional feature on X-ray chest is the dilated aortic shadow. Inverted Y-shaped ductal calcification may also be seen with PDA and Eisenmenger syndrome. Usually, partial anomalous pulmonary venous drainage is associated with sinus venosus AST, and the X-ray findings are those of AST. In isolated partial anomalous pulmonary venous drainage, one specific variety is scimitar syndrome. Scimitar syndrome is characterized by partial anomalous pulmonary venous drainage of the right lung hypoplasia, dextroposition of the heart, and anomalous systemic arterial supply from aorta or one of its branches to the right lung, sequestration. In scimitar syndrome, partial anomalous pulmonary venous drainage from the right lung is into the inferior vena cava. In partial anomalous pulmonary venous drainage associated with ASD, it usually drains to the superior vena cava right atrium junction. The partial anomalous pulmonary venous drainage in scimitar syndrome appears as a curved shadow in the right lower zone, resembling a curved sword which was known as scimitar. The shadow dips down below the diaphragm as it courses towards the inferior vena cava. Familial scimitar syndrome has been reported in 2 sisters. Diagrammatic representation of scimitar sign in chest X-ray. Diagram of a partial anomalous pulmonary vein draining towards the inferior vena cava from the right lung has been superimposed on a chest X-ray and marked by white arrows. Discussion on Andexanet alpha, antidote for factor Xa inhibitors. Andexanet alpha is a recombinant modified human factor Xa decoy protein which reverses the effect of factor Xa inhibitors like rivaroxaban by binding to these drugs. It does not have intrinsic catalytic activity. In other words, it is a modified recombinant inactive form of human factor Xa which bind and sequester factor Xa inhibitor molecules. The drug competes with endogenous factor Xa to bind with factor Xa inhibitors, thus elevating levels of free endogenous factor Xa. Andexanet alpha was evaluated in ANNEXA-4 prospective multicentric open-label trial. In the interim report published in 2016, the medication was used in 67 patients who developed acute major bleeding within 18 hours of administration of a factor Xa inhibitor. The mean age was 77 years and bleeding were mostly gastrointestinal or intracranial. The drug was given within 4.8 plus minus 1.8 hours of presentation to the emergency department. After Andexanet bolus, median anti-factor Xa activity decreased by 89% in those receiving rivaroxaban and 93% in those on apixaban. The bolus dose was followed by a 2-hour infusion. Assessment at 12 hours showed good hemostasis in 79% of patients. Thrombotic events occurred in 18% during a 30-day follow-up. The occurrence of thrombotic events is always a concern in the reversal of any anticoagulation, mostly attributed to the high thrombotic risk in these individuals in whom anticoagulation was clinically indicated. Due to this thrombotic risk, anticoagulation should be reinstituted soon after the control of bleeding when medically appropriate. The full study report of ANNEXA-4 was published in 2019. ANNEXA-4 evaluated a total of 352 patients who had acute major bleeding within 18 hours of administration of a factor Xa inhibitor. Acute intracranial hemorrhage was present in 64% of the patients. Patients in the study received a bolus of Andexanet followed by 2-hour infusion. Co-primary outcomes evaluated were the percentage change in anti-factor Xa activity, and percentage of patients with excellent or good hemostatic efficacy at 12 hours after the end of the infusion. Excellent or good hemostatic efficacy at 12 hours was documented in 82% of the patients. 92% reduction in median anti-factor Xa activity was noted in those who were on apixaban and rivaroxaban after the Andexanet bolus. Before the availability of specific antidote, bleeding due to factor Xa inhibitor was treated with non-specific agents like prothrombin complex concentrate, fresh frozen plasma, and activated recombinant factor 7A. The dose of Andexanet alpha needed is based on whether it is used to reverse rivaroxaban or apixaban, the dose of the factor Xa inhibitor which was being used, and the time since the last dose. Discussion on fractional flow reserve or FFR for guiding percutaneous coronary intervention and functional syntax score. Coronary angiography gives a visual impression about the severity of the stenosis, but it need not imply the actual functional significance of the stenosis in terms of flow physiology. It is often difficult to decide which are the flow limiting lesions when there are multiple stenosis in same or different territories. It is here that the fractional flow reserve estimation helps. FFR is estimated using a guide wire with a pressure transducer. FFR wires have properties similar to the floppy guide wires so that they can pass across coronary lesions back and forth easily to assess the pressure drop across the lesions. The flow reserve is calculated after inducing maximal hyperemia in the distal territory with intracoronary adenosine or papaverine or intravenous adenosine given in a central vein. FFR is obtained by dividing the pressure distal to the stenosis by the central aortic pressure, which is usually equal to the pressure proximal to the stenosis if there is no additional stenosis in between. Normal FFR is 1.0 and an FFR below 0.75 indicates inducible ischemia, while an FFR above 0.80 excludes ischemia in 90% of cases. So, it is evident that the gray zone in FFR evaluation is very limited. FFR measurement is successful in almost 99% of cases and the values are reproducible. If the FFR normalizes after stenting, the restenosis rates at 6 months is less than 5%. Since the FFR wire can be used for guiding balloon catheters and stents, it is easy to make post-procedure measurements without any additional effort. When there are multiple stenosis, the wire will pick up the pressure drop at each lesion so that we can decide on which all lesions are significant and needs tackling. Fame study showed that at 1 year follow-up, rate of major adverse coronary events was reduced by approximately 30% by routinely measuring FFR. Routine FFR measurement probably led to more judicious use of stents and improved outcomes. Fame study had randomly assigned 1005 patients with multivessel coronary artery disease to either percutaneous coronary intervention with drug-eluting stent implantation guided by FFR or by angiography alone. Cutoff of FFR was 0.8 in the study. Lesions with FFR more than 0.8 were left on medical treatment in the FFR guided PCI arm. Naturally, the FFR guided PCI group received lesser number of stents. They had lower rates of mortality or myocardial infarction. PCI or coronary artery bypass surgery rates were also lower, though not statistically significant. The lesions deferred on basis of FFR had only 0.2% myocardial infarction rate and 3.2% revascularization rate at 2-year follow-up. A downside of the study was that it had included lesions of 50 to 79% stenosis also. but the authors justify their decision mentioning that 35% of these lesions were hemodynamically significant and leaving them untreated based on angiographic appearance alone would not have been ideal. Another potential drawback of the data is that theoretically the lesions left alone based on FFR can also progress beyond the study period of 2 years and present later with significant stenosis. Fractional flow reserve is the fraction of the maximal coronary flow that remains in the presence of an epicardial coronary lesion. Hence, it is useful in assessing the severity of lesions, especially in case of lesions thought to be borderline on angiography. The flow has contributions from the factors due to the epicardial coronary artery, myocardium and the collateral flow. Hence, a good collateral flow can lead to underestimation of the severity of stenosis estimated by FFR. Advantage of FFR over coronary flow reserve is that as it is calculated only at peak hyperemia, it is mostly independent of basal flow, aortic pressure, heart rate and the status of the microcirculation. There is a strong correlation between FFR and inducible myocardial ischemia. An FFR below 0.75 identified physiologically significant stenosis. In patients with coronary lesions, FFR can be used to identify patients who will benefit from percutaneous coronary interventions. An FFR of less than 0.90 after coronary stenting would predict a higher event rate of 20% and an FFR below 0.8 an event rate of 30%, compared with 5 to 6% event rates in those with FFR above 0.9. Guide catheters without side holes are preferred for FFR estimation. Contrast should be flushed out and the guide catheter filled with saline for good pressure measurements. Excess adenosine will have to be given to get adequate hyperemia if there are side holes for the catheter due to extra spillage of drug into the aorta. Matching of the wire tip pressure and the aortic pressure should be done before crossing the lesion. The level of the external pressure transducer should be adjusted to get a match of the tracings if necessary. Conventionally, the transducer position corresponds to a level 5 cm below the sternal level, indicating the level of the right atrium. A loose Y connector and a retained guide wire introducer can cause pressure leakage. Drift in signals can be identified by repeat matching of the pressures after the wire pullback. There is a limitation while assessing serial lesions, as the true FFR across a lesion can be known only after complete relief of the other lesion. There are formulae available for calculating the significance of individual lesions, but this will require measurement of wedge pressure, which can be done only during interventions and not during diagnostic catheterizations. FFR estimation using the Doppler wire is useful in assessing the need for a side branch stent in bifurcation disease. Usually a stent is considered in bifurcation disease only if the side branch is large and almost equal in size to the distal vessel. Using a side branch stent increases the risk of stent thrombosis in the main vessel and is especially to be avoided in a thrombotic situation as in acute myocardial infarction. If an FFR is available, it can measure the pressure difference across the lesion, and if the distal pressure is more than 0.7 times the proximal pressure, a side branch stent is considered unnecessary. Syntax score is calculated on a publicly available website using an online software. It can also be calculated on a downloadable software. It is used for coronary arteries with diameter more than 1.5 mm and having narrowing more than 50%. It also considers the potential difficulty in performing a PCI. Functional syntax score is an FFR guided syntax score. It recalculates syntax score by incorporating ischemia producing lesions determined by FFR. This reduces the number of high-risk patients and better discriminates risk for adverse events in patients with multivessel disease undergoing PCI. About 1/3 of patients originally thought to have high or intermediate risk were reclassified as lower risk by the functional syntax score. Functional syntax score was found to be better than syntax score in predicting composite of death, myocardial infarction and target vessel revascularization, as well as the composite risk of death and myocardial infarction at 1 year. FAME-2 study randomized 1,220 patients with stable coronary artery disease and angiographically significant stenosis in whom at least one stenosis had FFR 0.8 or less. They were assigned to either FFR guided PCI plus medical therapy or medical therapy alone. FFR guided PCI was associated with significantly lower rate of primary composite endpoint of death, myocardial infarction or urgent revascularization at 5 years than medical therapy alone. Those without hemodynamically significant stenosis who were entered in a registry had a favorable long-term outcome with medical therapy alone. Discussion on coronary angiographic views. Coronary angiography is done in multiple projections or views to get a three-dimensional idea of the coronary lesions. Some regions of the coronary arteries may appear foreshortened in certain views so that true length of the lesion may not be appreciated. Actual severity of eccentric stenosis can be ascertained only by multiple orthogonal views. Even though there are several conventional views for coronary angiography, unusual angulations may be needed in an individual case to guide coronary interventions. Often, a test shot is given before the actual cine run to see if the branches are overlapping or not. Common projections used in coronary angiography are left anterior oblique LAO, right anterior oblique RAO, postero-anterior PA or AP, and lateral views. In addition to these, varying degrees of cranial or caudal angulations can be added to these views. In general, proximal parts of major vessels are best seen in caudal projections. We will discuss the views for left coronary angiography now. Spider view or LAO caudal view is often the first view taken during coronary angiography. This view is useful in visualizing the left main coronary artery and its bifurcation into left anterior descending coronary artery and left circumflex coronary artery. LAO angulation may vary from 40 to 50 degrees and caudal angulation 25 to 40 degrees. LAO caudal view of left coronary angiogram resembles a spider and hence the term spider view. LMCA, left main coronary artery. LCX, left circumflex coronary artery. Lesion in LCX marked by yellow arrow. LAD, left anterior descending coronary artery. Early OM, early obtuse marginal branch of the LCX. From the LMCA bifurcation, LAD is seen towards the catheter side and LCX towards the opposite side in this view. Dye or contrast reflux into the aorta from the LMCA is seen. Absence of dye reflux would mean left main ostial disease or rarely spasm. This is a left coronary angiogram in LAO caudal view in another case. JL, Judkins left coronary catheter. Difference in the orientation of coronaries could be due to anatomical variations as well as mild changes in angulations used. X-ray penetration will be less in LAO caudal view, especially in obese individuals. In this view, mid-segment of LAD is foreshortened and hence This view should not be used during angioplasty of mid-LAD, but proximal region of LAD is visualized well. Proximal and mid segments of LCX are well seen in this view. Video of left coronary angiogram in LAO caudal view is shown here with annotation of branches in a still frame. RIO caudal view is another common view for the left coronary angiogram. Some operators use this as the first view. Usual angulation is 30 to 40 degrees to the right, but shallower views may be used sometimes to reduce respiratory movements. Sufficient caudal angulation to separate out the proximal portions of the LAD and LCX is used. Proximal and mid portions of LCX and bifurcation of marginal branches are seen. It is a good view for the distal LAD. Diagonal and septal branches may superimpose on the proximal and mid LAD in this view. Left coronary angiogram in RIO caudal view showing a tight lesion in the obtuse marginal branch of the left circumflex coronary artery. LAD, left anterior descending coronary artery. The OM lesion is marked by the blue arrow and is seen in the proximal portion of the obtuse marginal, which is a major branch of the left circumflex. This is a left coronary angiogram in RIO caudal view from another case. Distal LAD is seen well in this case. Diagonal and septal branches are overlapping the mid LAD as mentioned earlier. PA cranial view is ideal for most lesions in the proximal and mid LAD. A cranial angulation of 40 degrees shows the diagonal and septal branches in opposite directions well separated from the LAD. Left coronary angiogram in PA cranial view showing a proximal plaque marked by an arrow in LAD. In this case, a recanalized vessel after anterior myocardial infarction. Septal and diagonal branches of LAD are also seen. Almost the whole extent of the LAD is seen well. Proximal left circumflex is foreshortened in this view. Rightward angulation, RIO cranial, is useful in reducing the overlap of proximal LAD by the vertebral spine and the catheter. It may be noted that in both cranial views, the diaphragmatic shadow goes high up into the field. Video of left coronary angiogram in RIO cranial view showing a complex lesion in the LAD. The LAD can be seen wrapping around the apex, type 3 LAD. In type 1 LAD, it will stop short of the apex and type 2 will reach up to the apex. LAO cranial view straightens out the proximal and mid LAD. Diagonal branches are seen on the same side as the obtuse marginal branches. Septal perforators are seen to the opposite side. In this left coronary angiogram in LAO cranial view, OM branches of LCX are seen overlapping the spine. Diagonals are seen running down between the spine and the LAD. Septal branches are seen on the opposite side but almost parallel to the LAD. Lateral view is seldom used and ideally requires the positioning of the hands above the head to avoid superimposition of patient's arms. But this requirement is not there when the field of interest is in the distal part of the LAD, which is anterior. The same applies to visualization of the anastomosis between the left internal mammary artery and LAD. Lima to LAD coronary bypass graft in lateral view. The image has been darkened a bit by post-processing to visualize the Lima and LAD well. Since it was an injection into the left subclavian artery just near the Lima ostium, the contrast density was a bit lower than that of a superselective Lima injection. The sternal wires indicate the post-sternotomy status. Distal flow into the LAD is good. Retrograde flow from the anastomotic site into the proximal part of LAD is also seen. Now we will move on to views for right coronary artery. RIO view shows the conus branch and sinus node artery in opposite directions as seen in this image. Right ventricular branches and posterior descending artery are seen well. Multiple septal branches can be seen arising from the PDA. PDA has a mild lesion in the proximal portion. In the angiogram illustrated, the posterior left ventricular branch is occluded and only a stump, PLV stump, is seen. Atrioventricular nodal artery usually originates near the bifurcation of the right coronary artery into PDA and PLV. Here is another right coronary angiogram in RIA view. Here the septal branches of PDA and PLV are seen well. RIO view shows the proximal part of the right coronary artery in a vertical line. RIO view is identified with the spine seen on the right side. Tight stenosis is seen just before the origin of right ventricular branch. LAO view usually shows the full length of the right coronary artery in a C shape. Distally, the right coronary artery divides into PDA and PLV at the crux caudis. Crux caudis is the junction of the atrioventricular and interventricular grooves posteriorly. The artery which crosses the crux is defined as the dominant coronary artery. Right coronary dominance is much more common than left dominance. Even when the right coronary artery is dominant, the major portion of left ventricular myocardium is supplied by the left coronary artery. PA cranial view of right coronary angiogram is shown here. As in other cranial views, diaphragmatic contour can be seen high up in the field. A tight lesion is seen in proximal portion of PDA marked as 1. PLV, posterior left ventricular branch, AM, acute marginal branch, RCA, right coronary artery. Conus branch of the right coronary artery. Sometimes while cannulating the right coronary artery, the catheter slips into the conus artery. This causes wedging and damping of catheter tip pressure. Prolonged inadvertent injection of contrast into the conus branch can cause ventricular tachycardia or ventricular fibrillation occasionally. A large conus branch crossing the right ventricular outflow tract can cause problem during intracardiac repair of tetralogy of Fallot. LAO cranial view of right coronary angiogram using an Amplatz right catheter is shown here. This RCA was difficult to cannulate with Judkins right catheter even after repeated attempts. The angiogram shows only minimal luminal irregularities of the RCA. Right ventricular branches are seen originating from the proximal region. Terminal branching of RCA into posterior left ventricular PLV or PLB branches and posterior descending coronary artery are also seen.